All right, welcome everyone. Today we are diving into a really fascinating story. A story about how a bacterium we used to just ignore, write off as a simple contaminant has turned into a major threat. I'm talking about Staphylococcus capitis. We're going to explore how this bug, a normal resident on our skin, became a really serious problem, especially in our neonatal intensive care units. Now, all the info we're covering today comes from a deep dive using Gemini Deep Search. And for all of you who want to check out the primary sources for yourselves, don't worry, we've linked the full notebook document for you.
Yeah, for the longest time, if you saw Staphylococcus capitis on a culture plate, what was the first thought? Contaminant, right? I mean, it's everywhere on our skin, so you just assume it was from the skin prep or the collection itself. It was basically microbiological noise.
But that's just not the case anymore. That whole perception has been completely flipped on its head. Now, this very same organism is one of the top causes of late-onset sepsis in the most fragile patients we have. So you have to ask, how on earth did that happen? How did a harmless skin bug become such a villain? That's exactly what we're going to unpack today.
Okay, so let's get our bearings. What are we actually dealing with here? Well, Staphylococcus capitis was first put on the map back in 1975 by Kloos and Schleifer. And in the lab, it's a textbook coag-neg staph. You know the drill. Gram-positive cocci, they look like little bunches of grapes under the scope. On a blood agar plate, it grows out pretty easily in air, giving you those typical non-hemolytic, kind of opaque whitish colonies. And its name, capitis, gives you a huge clue about where it loves to hang out. It's Latin for of the head. So yeah, its prime real estate is the skin, especially the oily parts like your scalp and face.
Okay, but here's where the story takes a turn. It's not enough to just say Staphylococcus capitis anymore. That's way too broad. We've got to go deeper, because the species is actually divided into two really important subspecies. You've got subspecies capitis, and then you have subspecies urolithicus. And believe me, knowing which one you're dealing with, well, it changes everything.
So how do we tell them apart? It actually comes down to a couple of classic, straightforward biochemical tests. We're talking urease and maltose fermentation. It's a really clean split. Subspecies capitis is negative for both. Subspecies urolithicus, positive for both. And this isn't just some trivia for a lab exam. No way. These simple reactions are actually massive clues that tell you a lot about how the bug is going to behave in a patient.
Right, because these markers aren't random. They're linked to some really nasty traits. When you isolate subspecies urolithicus, you're looking at an organism that is way more likely to be multi-drug resistant. It's also a champ at forming biofilms. And when you see a nosocomial outbreak, especially in a NICU, guess who's almost always at the scene of the crime? Yep, subspecies urolithicus. And I just said the word biofilm, and we have to pause on that for a second, because for Staphylococcus capitis, this is its superpower. It's probably the most critical weapon in its arsenal. I mean, think of it. This bug builds its own slimy fortress around itself. That matrix lets it stick like glue to surfaces and, more importantly, it acts like a physical shield, hiding the bacteria from the patient's immune cells and, you guessed it, from our antibiotics. This biofilm-forming ability is exactly what makes Staphylococcus capitis what you could call a pathogen of medical progress. It's a bit ironic, isn't it? All of our incredible medical advancements, central lines, prosthetic valves, pacemakers, shunts, we've basically rolled out the red carpet. We've created the perfect, non-living surfaces for this bug to colonize and set up these incredibly stubborn biofilm-based infections. But the rabbit hole goes even deeper. Let's zoom in on those neonatal infections, the ones causing so much trouble in NICUs all over the globe. The story gets incredibly specific here. We're not just talking about any old Staphylococcus capitis. It's not even just any strain of subspecies urolithicus. No, what we're seeing is the work of one single, globally successful clone.
And here it is. This is the main character, or rather the main villain of our story, the NRCS-A clone. This thing is something else. It has adapted to the NICU environment in a way that is just, well, it's terrifying. It really is the perfect storm in a microbe. It's loaded with resistance genes, and it's uniquely equipped to survive and thrive among the most vulnerable patients, all while being constantly bombarded with antibiotics.
Okay, so faced with this super adapted bug, what's our game plan? How do we fight back? Well, when you're dealing with an infection tied to a medical device, the strategy is actually very, very clear. Rule number 1, 2, and 3 is source control. You have to remove the colonized device. Get that catheter out. Seriously, this is the single most important step. A lot of the time, just doing that solves the problem. You might not even need antibiotics. But if you do need to treat, your first-line agent is going to be vancomycin.
And if you look at international guidelines like the Dutch swab guidelines, they really hammer this home. For a catheter-related bloodstream infection, their top recommendation in big, bold letters is remove the central line. The antibiotic of choice, intravenous vancomycin. For adults, that's typically 15 to 20 milligrams per kilogram every 12 hours, but always guided by therapeutic drug monitoring. And the duration makes perfect sense too. If the line's out, 5 days might be enough. If, for some reason, it has to stay in, you're looking at a longer 10-day course.
Of course, all of this is backed up by solid data from the microbiology lab, using standards like the EUCAS clinical breakpoints. As you can see here, we've got the key players. Your cefoxitin screen is your first stop, your sentinel test for methicillin resistance. And then, of course, the vancomycin breakpoint is absolutely critical. But there's a catch with vanco, isn't there? The whole tricky issue of heteroresistance, which our standard MIC testing can sometimes miss completely, adding another layer of complexity.
Okay, so that's the adult picture. But now, let's take everything we've just talked about and shrink it down to a patient who weighs maybe 2 pounds. The complexity just explodes. Treating neonates is a whole different ballgame. It's a huge pharmacological puzzle, mostly because their tiny, developing bodies handle drugs in ways that are incredibly variable and unpredictable.
Yeah, so there's absolutely no one-size-fits-all dose here. It is an incredibly careful calculation that takes into account both postmenstrual and postnatal age. And the target we're aiming for has gotten a lot more sophisticated. We've moved beyond just looking at simple trough levels. Now the goal is a specific pharmacokinetic/pharmacodynamic target. We want the 24-hour area under the curve to MIC ratio to be at least 400. That's what it takes to be confident we're getting the job done.
So this all leads us to the final and maybe most important piece of the puzzle. How do we stop this from happening in the first place? Time and time again, when people investigate outbreaks of this clone, all fingers point in the same direction. And this quote says it all. The NICU environment itself becomes this incredibly resilient reservoir. We're talking about the incubators, the equipment, the high-touch surfaces. They become a safe haven for the NRCS-A clone.
So what's our defense? It's all about rock-solid, back-to-basics infection prevention and control. It starts with the single most effective thing we can do, perfect hand hygiene, period. Then you add on contact precautions for any infant that's colonized or infected, gowns, gloves, the whole deal. And it means being absolutely relentless with environmental cleaning, especially those high-touch surfaces. And when you do have an outbreak, our tools have gotten way more powerful. Whole genome sequencing is now the absolute gold standard for playing detective and tracking transmission with pinpoint accuracy.
Which really brings us to a huge, forward-looking question, doesn't it? The whole story of Staphylococcus capitis and this one dominant clone, NRCS-A, has taught us a powerful lesson. Just identifying the species isn't going to cut it anymore. So looking ahead, especially in these ultra-high-risk environments like the NICU, is it time to make clone-level surveillance the new standard of care? Is that what it's going to take to get ahead of these hyper-adapted bugs?
So there you have it, the incredible journey of Staphylococcus capitis from a simple skin commensal to a major neonatal threat, all driven by the emergence of the NRCS-A clone. It really forces us to think differently, to look past the species name on a lab report. So I'll ask you again, what are your thoughts? Is routine surveillance for specific clones the next frontier in infection control? I'd genuinely love to hear from those of you on the front lines, so please share your experiences and opinions in the comments. And hey, if you got something out of this explainer, do us a favor and subscribe to the channel. Thanks so much for tuning in.